mental health kinds of questions. But that one is one I've seen a lot. So that one I did throw out, but I wouldn't throw it out again. Just be aware, if you may see it again, you might want to remember that Clozaril has to be monitored with WBC levels. The other thing I noticed as I was going through there, and I've talked to a few of you, come by my office, so I've talked to a few of you. Some of you just chose answers you knew were wrong because you can tell me what the right answer was without even seeing it again. I can tell you what the question was and you can tell me what the right answer was. So that tells me you knew it, you just didn't choose that answer. Why do you suppose somebody would do such a thing? I'm sorry? Second guessing? Not feeling sure of your knowledge? I like to think it's because you want to spend one more semester with me because you like me so much. You saying that's not it? Yeah, not sure of your knowledge, being uncertain of yourself, being insecure with your knowledge. And so I think that's a huge area. That you'll see a question, you may know what the answer is, and then you think, well, it can't be that because I wouldn't know that answer. I'm not smart enough to know that. And so you'll talk yourself out of it. I've seen that a lot over the years, and I need for y'all to stop doing that. We need for you to get more secure in your knowledge base. Luckily, this exam did not hurt anybody to the point that somebody couldn't pass, because the first one counted so small. So even the worst score in here, the worst two average, the two test average, the worst one only needs an 80 on the remaining exams, which is not impossible to do. So everybody can still pass. And so what we need to do is to work on passing. I did set up the sessions to meet with me on Tuesday, Thursday. They're on D2L, 15 of you at a time. They're set by week. What I do on Tuesday, I'll do again on Thursday, so there's no need to do both of them. So you can sign up in those. Some of you have been assigned to a nursing instructor, so that person's going to meet with you to go over the same content that I'll be going over in my meetings. If you did not get an 80% on the first exam, and you also did not do well on the second exam, I suggest, but you're not assigned to a faculty member, I suggest you do come for sure. Those people I think should come for 12 hours in those small group meetings to go over content because you're probably a little higher risk than others. For the rest of you who did not get the 74% on this exam, rather than come and see me in my office right away, what I'm going to do is I'm going to post that little form that you're supposed to fill out when you come see me that says what you're going to do to get this grade higher. I'm going to post that form. I want you to fill out that form. So anybody who didn't get a 74 or higher on exam 2, I want you to fill out that form. And you can bring it to me, you can email it to me, I don't care how you get it to me, but I want it back. And then, what I want you to do is I want you to do 100 questions. Now, that's not going to be a hardship because you've got to do 150 in your pass point exam, right? On those 100 questions or 150 questions, what I want you to do, these are people who made less than a 74 on this last exam. I want you to take one of your pass point exams, the one you do most recently, not one you've done in the past, one you've done most recently. I want you to go back and look at the questions that you missed. And this is what I want you to tell me. I want you to take out some paper, and I want you to discuss on every question you missed out of that 150, okay? I want you to tell me what it was asking about. I want you to tell me what the correct answer was. Is anybody writing this down? If you made less than a 74, you don't want to write it down because people think you made less than a 74. Just have you write it for your neighbor because they were, not smart enough to write down because they made less than a 74, so you had to do it because you're 92. You need to write this down. I want you to know, I want you to write what the question was asking about, what the correct answer was, and why it's the correct answer. So what the question was asking about, the correct answer, and why it was the correct answer. And then I want you to tell me why you missed it. And there's only 4 reasons that you missed it. 1, you just didn't know the content. It was Clozaril, and you just didn't know it. 2, it could be that you misread the question. It was one of those questions that said, all of these belong except this one, and you just missed that it said except. So you could have just misread the question. Third, you didn't know what the question was asking you. Have you ever had those questions where you look at it and say, I can't really tell what they even want to know in this question? So sometimes it's just you don't know what it's asking you. And the fourth one is you thought you had the right answer, but you weren't sure, and you just changed your mind. So you're going back and forth, what I call the what-ifers. You ever heard yourself say that? I think this is the right answer, but what if? What if the patient's married? What if the patient has a history of? What if? Anybody ever done that in a question, be a what-ifer? So that's your fourth reason, you what-ifed it. And I want you to do this just on the ones you missed. And the reason I want this is once I get this in my hand, I can pretty much tell you why you're missing the questions you're missing. And there's a strategy for each and every one of those. There's a strategy. This meeting in my office to go over and you tell me what it is that you need to do to improve doesn't work. It's not working because you don't know what you need to do to improve. And the ones who have come to see me have pretty much said that. I am lost. I don't know what to do. I don't know how to get where I want to go. And I can't help you unless I know what the problem is. So that's what it's going to do. Is that's going to give me the answer to what the problem is. So if you got a 74 or less on this test, then I want you to do that exercise. I want you to send it to me. You can email it to me. You can fax it to me. You can bring it to me. I don't care how I get it, but I want it. Everybody understand? And then I want you to also fill out that form just so that Dr. Williams is happy. But after I get those homework assignments back, I'm going to tell you what your problem is, and then I will tell you how to fix it. And we'll all pass this class. Okay, tonight we're going to, is there any questions over exam 2? All right. I will send the rationales. We got 2 students that still need to take it. I will send the rationales for the questions that you missed as soon as they take it. Okay. Cardiac rhythm strips and EKGs is what we're going to go over tonight. Everybody see I revised the calendar? Yes?
I never saw the rationales for the very first system too.
The rationales for the first one, you didn't get rationales. What you got was, because it was like an NCLEX assessment, you should have gotten something that tells you what area of the NCLEX test plan that question was from. Okay? All right. Okay, so we're going to go over, everybody saw the calendar revisions. Okay. If you come to the small group meetings, make sure you bring your NCLEX review book. The Saunders one that's required for this course, you want to bring in. Well, today we're going to go over cardiac rhythms and strips and EKGs. Most of this should be a review, if not all of it's a review. This is the little grid that we would see when we are evaluating a rhythm strip. And each one of those little squares, each one of those little tiny squares is 0.04 seconds. So these little squares tell us time. They tell us time. So each one of the little squares is 0.04. And then when you have the bigger squares, because you'll see these darkered out, then that was 0.2 seconds. But you really don't have to remember that. You have to remember the 0.04 seconds is one small square. The thing that we're also going to look at are these complexes. We've got the P wave. If it's perfectly normal, it would look like this. And that is atrial depolarization. That little P wave is created during atrial depolarization. Then you have the QRS. The QRS is created during ventricular depolarization. I have a little space here, and then you have the T, and the T wave is created during ventricular repolarization. The reason we do not have a wave for atrial repolarization is because it gets buried in the QRS, so we can't see it. Then we have some segments. We have the beginning of the P wave to the beginning of the Q wave, and it's called the PR interval. The beginning here to here is called the PR interval. We also have another little segment from the end of the S to the beginning of the T, and that's called the ST segment. We're going to be most interested in this PR interval depending on how much time lapse between the beginning of the P and the starting of the QRS. How much time elapsed. So it's going to be a time issue with the PR interval. Whereas the ST segment, we're not so much interested in the time, we're interested that it falls back in baseline. This was perfect. Most of them are not going to be that perfect. Or if this ST segment rises or drops below the baseline. So with the ST segment, we're interested in where it lies in comparison to the baseline strip. The PR interval we're interested in as far as time is concerned. We are also interested in the height, and you will hear people talk about that as gain. It's gain. And it can be changed with just a knob. You can turn the gain down, you can turn the gain up with just a knob. But there are some conditions that if the height changes without adjusting that knob, then it tells us something about that patient's condition, such as cardiac tamponade. You'll see the gain will go down, they'll get shorter. Those QRSs and everything will get shorter, but you haven't adjusted that knob. So there are some conditions that the height is very important. So this is the 12-lead EKG. A lot of what we're going to talk about today, we're just going to talk about with the rhythm strip, which is just this part. But this shows us all the different ways the heart can be analyzed with 12 leads when you put a 12-lead EKG on there. And each one of the little strips are so tiny. They're just so tiny because you've got 12 of them on there. And changes in the different leads and what corresponds with them will help the provider know if there is a myocardial infarction or not. Also, you'll see things like this really coarse looking line here and here. They'll call that noise or static. That is just something has disrupted the tracing. It's not the patient's heart. It's just something has disrupted the tracing. But it can be so bad that you lose the ability to diagnose that particular lead. So a lot of times when you see people doing these, they'll do them over and over to try to get rid of any noise or any static that is in that EKG. Because since you only have little tiny short strips in each one of these leads, then we need them to be as clean as possible. We can also look at rate with a rhythm strip. And when we do that, what we do is pull off a 6-second strip. A 6-second strip. And the way you'll know that is there's going to be some little markings, either above or below. I put these below. But there's going to be some little markings, and I exaggerated these. From this mark to this mark is 3 seconds, and then from this mark to this mark is another 3 seconds. So you pull off the 6-second strip to do the analysis. One of the first things you would do with this strip is determine if the rate is regular. And the way I do that is I take an index card and I mark a line with one of the QRSs in line and then with the other one. So I lay the index card down and I mark this line and I mark this line. Then I march this thing across. I move that index card so that this one now is aligned here and this one now is aligned here. And if it's falling on a QRS, it was regular. Then I would march it across. So now this one is here. This one is here. And if they're still hitting on the QRSs, then it's regular. So that's how I do it. It's a quick and dirty way. I take a little index card and just march it across to see if it's regular. And this one looks to be pretty regular, doesn't it? The other thing we can do as a quick and dirty is we can look at how many PQRSs there are in the 6 seconds. So we can count this, 1, 2, 3, 4, 5, 6, 7, 8. And if we wanted to know what the heart rate was per minute, and we've got 6 seconds, then we just can multiply that by 10, right? So we would have 80 beats per minute. So that will tell us the heart rate. So I'm thinking this is an 80 beat per minute heart rate, and that it is very regular. Everybody see that? Okay. This is normal sinus rhythm, and the reason it's normal sinus rhythm is because there is a P wave for every single QRS. A P wave for every single QRS. That's all it means to be sinus. Because all that means is that the atrial node is the one that is triggering the heart to beat. It's not using the AV node or the junctional node. It's using the SA node. So it'll put a P wave in front of every single QRS. And that tells us it's sinus. So this one's nice and normal. What makes it normal? It's 80 beats per minute, right? That's a normal heart rate. This is an adult, 60 to 100. So this is normal sinus rhythm. So now we look at this one, and we see that it's very regular, isn't it? Very regular up here. And it's a 6-second strip. So let's count the beats. 1, 2, 3, 4, 5. So what's the heart rate? 50 beats per minute. Is there a P wave in front of every QRS? Well, there's a P wave. 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 So there's a P wave in front of every QRS. So it is sinus, and it is regular, but it's slow, isn't it? Also, when I look at this strip, those P waves look like they're awfully far apart. And I could count the little blocks. See, this one starts right here on the line. So I go 1, 2, 3, 4, 5. 5 little blocks at 0.04 tells me that this is at a 0.2, right? That isn't too far. That's right at the edge, though. Greater than a 0.2 would tell me that it was a heart blocker sometime. This one's right at the edge. And then as we go along, look at these T waves. Here's a T wave. What happened to it? It's upside down, isn't it? It's upside down, and when it is upside down, it kind of brings that little ST segment up, doesn't it? Look how high that ST segment is there. Very, very high. So this is what we call ST elevation with an inverted T wave. Could be an MI, might just mean old ischemia. Inverted T wave more often than not in lead 2, and all what we're going to talk about today is lead 2. And lead 2 are usually just old ischemia, but it could be an MI. So now we go down to the next one, and we're looking for P waves. I don't see a P wave here. There's one. There's not one there, is there? There's one. There's not one there. And there's one. So we don't have a P wave for every QRS, do we? Is it regular? It's regularly irregular, isn't it? I mean, you've got, we can't see this, but we can assume by this there's probably a beat right there. Then you have these pairs together. Then you have these pairs together. They call those couplets. So it's regularly irregular. And we can see that P wave is really far. Let's see here. 1, 2, 3, 4, 5, 6, about 7. 7 blocks away. So obviously it's a heart block. It's a type of heart block where one of the P waves is dropped from the strip. Then we look at this one, looks very nice and regular, doesn't it? But do you see any P waves? I don't see a single P wave. I don't see a single keyway. Actually, this one, I will be pumping the gain up to see if I can see any kind of activity along this line. Because when it's that regular, I'm wondering, why is there no keyways in there? And what's the heart rate here? 1, 2, 3, 4, 5, 6, 7, 8. Heart rate's about 80, right? Very regular, but there's no keyway. And then this one's 1, 2, 3, 4, 5, only about 50. So this one came from a simulator, and it has a P wave for every QRS, doesn't it? And if we look, that P wave is short, it's nice, it's where it's supposed to be. QRS looks good, it's not too wide, it's not too skinny. The T wave is upright. The ST segment's a little bit depressed, but certainly not enough that we would be concerned about a heart attack. And so this looks all pretty normal. Then the rate is 1, 2, 3, 4, 5, so the rate is 50. Is it sinus? It's sinus. It's just slow. And we call that sinus bradycardia. So that's what that would look like. Sinus bradycardia is normal for athletes, caused by increased vagal tone or decreased sympathetic tone. We would only treat sinus bradycardia if there was a decrease in perfusion. So how would we know if there's a decrease in perfusion? Well, we've talked about that already a lot. We would note changes like differences in color, motion, temperature, sensation, the pulses, the cap refill, level of consciousness. One of the questions I got y'all on is you're checking for perfusion and you didn't pick up that there was a change in level of consciousness and there was diaphoresis. That's a change in perfusion. Color, motion, temperature, sensation, pulses, cap refill, level of consciousness, urinary output. Those are the things we look for with perfusion. Bradycardia is treated with atropine. Can it be also treated with these other things? Yes, the reason atropine is in blue is because on NCLEX they're going to ask about atropine. They're going to ask for you to know that we treat bradycardia with atropine. So now let's look at this one. We got a P for every QRS, there's the T. A P for every QRS. The T, everything looks good, not a whole lot of problems, regular as it can be, and it's a 6-second strip, so it's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. That was not quite complete, so we'll say 12. So what's the heart rate? 120. It's sinus, but it's fast, so what are you supposed to call this? Sinus tachycardia. Exactly right. Normal response to exercise. Normal response to saying, oh, by the way, we have a graded quiz today. Whew, tachycardia all over the room, right? That's normal. Anxiety, fever, fear, pain, any of those things can cause us to have a sinus tachycardia. Again, it is treated if it causes a decreased cardiac output, which is just another way of saying a loss of perfusion. If you start to see decreases in perfusion, then we treat it. Otherwise, we do not. It can be treated with all of these drugs. Digoxin is one you really want to particularly remember. However, I always like to highlight that digoxin, beta blockers, and the calcium channel blockers are what I call your rate control drugs. They're the ones that are going to slow your rates down. So if you have a condition that you need to slow the heart rate down, remember digoxin, beta blockers, and calcium channel blockers. Those are the ones you're going to use over and over and over. If you want to speed it up, you're going to use atropine. So write that in your notes and remember it. If we want to speed the heart up, we use the atropine. If we want to slow it down, we use digoxin, beta blockers, or calcium channel blockers. There's one special exception, and we'll get to that one in a minute. Okay, so this one's going along. All these pink ones are simulator strips. The black ones are real patient. But this one's going along. We got a P, we got QRS, we got T, we got T, we got QRS, we got T, we got P, we got QRS. we got a T, we got a P, we got a QRS, and then our T and our P kind of run in together, and then we have a QRS, and there's another T, a P, a QRS, T, PQRS, T, PQRS, and then we're going to have the exact same beat we had here over here. You can see that that was about to happen. And when you look at the regularity, it's regular from here to here and here to here and here to here, but it got a little irregular there. But then it's going to pick back up with regular here to here and here to here. Everybody see that? So we have this beat. It was going along at this, and so it ought to have hit about right there, but it came early. So they call that premature. They call that premature. And if it comes early and there is a P wave, if it comes early and there is a P wave, then most of the time that's a premature atrial beat, or premature atrial contraction, depending on whatever book you're looking at. So we had normal sinus rhythm, but we had one premature atrial beat. We call that ectopy. Ectopy. So that's all that one is. Sinus with a PAB. Now this terminology is what was used in your Lewis textbook, and that's why I use it here, but a lot of times you hear them called contractions. PAC. It's generally caused by stress or the use of caffeine or tobacco products. Sometimes some of your cold medicines will do that. Dehydration can do that, which is one of the reasons that caffeine can cause it. So these things, a lot of different foods and medicines can cause these little PABs. It can be caused by more serious things. Hypoxia, atrial enlargement, infection, inflammation, myocardial ischemia, all of that can cause it. They are generally not treated. If they're going to be treated, they've caused some problem. What problem? Poor perfusion, that's right. They're going to be used, treated if they cause poor perfusion. It's just most of the time they don't. They might be a little bit annoying to the patient. They can feel a little funny, but most of the time they don't cause a change in perfusion, so they're not treated. So this one, we got a PQRST, PQRST, PQRST. It's all nice and regular, PQRST. And then we had one come early, didn't we? And there's no P. Then you got a T, you got a PQRST, and then you had another one come early, and there's no P. And you have PQRST. This one, the P wave is buried in this QRS, and that's because it's not the SA node that's making the heart do what it's supposed to do. It's delayed. It's going on to the AV node, and we call these junctional beats. That P wave can come before the QRS, but it will be right up against the QRS. It can even come after the QRS. If it's junctional, you may see the P wave either right before, and I mean right before, butted up against that QRS, or immediately thereafter. Or it may not show at all because it's buried into the beat. But the QRS is going to look normal, and it's going to be coming early. And that sinus was a junctional beats, premature junctional beats, PJBs. Almost sounds like peanut butter and jelly sandwiches, doesn't it? Can occur from either the junction of the atria and the AV node, or the junction of the AV node and the bundle of His. It occurs in the normal heart as well as with pitch toxicity, ischemia, hypoxia, pain, fever, anxiety, nicotine, caffeine, electrolyte analysis. All we do with these is we treat the underlying cause. Again, this is a little bit more serious, but if it's not affecting perfusion, they may not do anything at all. Now we look at this one. We got a PQRST, PQRST, and then we got this wide bizarre QRS without any P or anything, and the T's all cattywampus. This wide bizarre thing. Then we have a PQRST, a PQRST, a PQRST. Then early we have this very wide bizarre QRS with the T all cattywampus, and then a PQRST. The reason we have this is because now the ventricles are having a premature beat. And the way we know it's ventricular is because that QRS becomes wide and bizarre. It doesn't matter if it's shooting down or if it's shooting up. Makes no difference. If you have two different types, you have one that's shooting up and one that's shooting down, then we have multifocal premature ventricular beats, multifocal, coming from different focuses in the heart, foci in the heart. If it all look the same, then it's unifocal. So this one's multifocal. Arises from an ectopic focus in the ventricles, generally associated with age and heart disease, but may occur in a normal heart. May occur with acute MI, binge toxicity, heart failure, hypoxia, stimulants, catecholamines, electrolyte imbalance, all the same things that cause any of the premature beats can cause this one as well. So all the premature beats are caused by the exact same things. They're generally not treated unless it affects perfusion. There is an old thought that if you got too many of these, that it eventually would become so pervasive that you had VTAC. And you will hear nurses that will say that. Well, we can't have too many of these beats in this strip because it may run into VTAC. Further research has shown that is not the case. You don't go from premature ventricular beats to VTAC. And so they will not treat these unless perfusion is affected. They will not treat them, no matter how many are coming, unless you've got a change in perfusion. So now let's look at this one. This one all looks pretty normal, except that P to PR interval looks long, doesn't it? If I can find one on a line. I'd like to find one on a line. Here's one. 1, 2, 3, 4, 5, 6, 7. It's just long, and it's long in all of them. A prolonged PR interval indicates first-degree heart block. And that's what that is. The only thing different between this strip and normal sinus rhythm is the PR interval is prolonged. It indicates first-degree heart block. Now look at that wacky one. Look at that wackadoo one. So we've got a P, QRST. This P is a little longer. That PR interval is a little longer than this one, isn't it? I got a QRST, and then look at this PR interval. It's even longer than this one, isn't it? And a T. Then we have a P way over here, but there's no QRS. Do you see that? Then we have a P that looks just like that one, a QRS that looks just like that one, and a T that looks just like this one. This is on a real patient. And then we have this prolonged little strip here from here. So it's longer than this PR interval, just like it was over here. T, and then we have a longer one again, and I'll bet you anything there's no QRS that goes with that one. So it's the P wave is getting prolonged until we drop a QRS, and then it goes back to normal, and then progressively gets prolonged again until we drop a QRS. Everybody see that on that strip? That is heart block Mobitz type 1. Heart block Mobitz type 1, or what they used to call leaky box. Nurses are going to call it leaky box. But the more correct term these days is Mobitz type 1. Now let's look at this one. We have a Q, a P, QRST. We have a P and no QRST. We have a P, QRST. We have a P and no QRST. We have a P, QRST. But that P wave is not changing on the normal ones, is it? And this kind of just kind of coupling along. You have a normal beat, then you lose your QRST. You have a normal beat, you lose your QRST. And that's Mobitz type 2. All right, this is a simulator. Now let's look at this one. We got a PQRS. Is that the T? Don't know, do we? Looks like a P. And a QRS, and what's that? That looks like a P wave too. And here's a P and a QRS. And maybe that's a T, but that might be another P wave. And there's a P and a QRS, and here's a P. Or maybe it's a T that goes with this. and a QRS. Can't really tell, can we? Can't really tell. When they don't seem to be working together, when there just seems to be waves across the page and they don't seem to be aligned with one another, that is third-degree heart block. You can have P's, more P's than you have QRSTs. You can have some QRSTs without P's. You might be losing some T's. You don't know what's going on. It just looks like they're just a bunch of waves across the page. That is third-degree heart block. Very, very serious. Very serious. In third-degree heart block, we will definitely be doing something to get that to work along in a much more confusing way. First degree, a lot of people have first degree, nobody even knows it. Now let's look at this one. We can't tell what's P's and what's T's, can we? One of the things we can tell is this is very irregular, isn't it? See that? Irregular. That one is that length, and then it's much shorter to there, and even much shorter to there. And this one might be close. No, I think this one's even shorter than that one. That's short. Then we got a long one that's very similar to this one, and a short one, an even shorter one, and then a little bit wider one. It's very irregular. And then when we look at our baseline, our P's and our T's all look about the same across. That irregular with that very coarse line through that tells me that this is atrial fibrillation. Atrial fibrillation. It may be transient in a normal heart. If it's chronic, it's generally associated with heart disease, but not every time. We may treat it with calcium channel blockers, digoxin beta blockers, the rate control drugs. And that's because not of the ventricular rate, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Ventricular rate's not that fast, but that atrial rate is just out of control. So they may treat it with the rate control drugs. I can tell you they will most definitely give this patient some form of anticoagulant. And the reason for that is you're not going to have good emptying of the heart if the atrium is fibrillating. You're not going to have good emptying of the heart if the atrium is fibrillating. And so blood can collect in there and become static and then clot. So they will definitely give this patient some form of an anticoagulant like warfarin or one of the new ones, Eliquis, and some of those newer ones that they have out now. Definitely do that. So the main thing you need to remember about atrial fibrillation. It's not usually in any way life-threatening. Usually patient doesn't even know they have it, and it usually doesn't affect perfusion. But the atrium is fibrillating, therefore they have a higher risk of developing clots, and so they're going to give them an anticoagulant. Main thing to remember about atrial fibrillation. Now this one, very regular. Very, very regular. But you can't tell P waves and T waves. This looks like a very sawtooth type of response. And a lot of times those sawtooths are also regular. Like in this case, they have 1, 2, 3, 1, 2, 3, 1, 2, 3. That's all. That's very often. This one has 4. Most of them just have 3. That you'll see that it's pretty regular, and the little sawtooths are even regular. This is atrial flutter. So much coarser, but what it does is those QRSs become regular. It's one of the easiest ways to tell the difference between atrial flutter and atrial fibrillation. Atrial fibrillation is almost always irregular, whereas atrial flutter is almost always regular. And that's why I said on one of the earlier ones, I punch up the gain and see if I can see some flutter, because it's so regular. That was a serious one as well. That'll be treated with, that's a calcium channel blocker, the Johnson calcium channel blocker, beta blockers. We may even do chemical cardioversion. If we do chemical cardioversion, a lot of times we'll use amiodarone. I should put that one in blue, it's one of the most likely to see. We may use electrical cardioversion. We may use either one. Atrial flutter is serious. They're going to try to reverse it. So far, which ones have we talked about that are serious? Atrial flutter, third degree heart block. Is that it? That's pretty much it, isn't it? Atrial flutter and third degree heart block. The others are probably only going to be treated if there's some perfusion issues. And then atrial fib, we have to remember the anticoagulant. So chemical cardioversion. Chemical cardioversion is where they give a drug to stop the heart in anticipation that when the heart starts back again, that it's a better rate, a better rhythm. So that's what they'll do. So this one was too fast. You can see this was probably supraventricular tachycardia. It was too fast. And so they gave the drug to stop the heart, and then when it started back up, it started at a slower rate. So you will see that sometimes that they'll do that. Particularly if the heart rate is very, very fast, that's when you'll see that. Electrical cardioversion is where they put the defibrillator on the patient, but they synchronize it. And they synchronize it so that the shock, when you give the shock, hits on the QRS and doesn't hit on the T wave. So they wanted to hit on that, so they synchronize it. So this would be one that they would do chemical cardioversion for. Look how fast this one is. That's fast, isn't it? That's fast. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18. 180 beats per minute. You can't tell what's a P wave, what's a T wave. You can kind of see that they have them. So what they call this, because they can't tell if it's an atrial, if it's a junctional, what they call this, they know it's not ventricular. It's not a ventricular abnormality because the QRS are thin. So it must be something other than ventricular. What it means then is it's above the ventricle, so they call that supraventricular tachycardia. Supra means above. It's above the ventricle, so they call that supraventricular tachycardia. This one is not going to perfuse long. I mean, people may have it an hour or two, but it's not going to perfuse long and they're going to wear out. So this is the one that you will see that they will treat with chemical cardioversion. And if they do chemical cardioversion, adenosine is the drug that they'll use. Adenosine is the drug that they'll use. And what adenosine is, it's a drug that you're going to give IV very fast. And slam it in, that's what they're going to tell you, just slam it in, and you'll slam it in, you'll watch the cardiac monitor as you do this, and that heart will stop. It will look like that one that we just looked at over here. It will look like this. And it's a long few seconds, because you're hoping that that heart starts again. And it always has for me. It'll start up soon thereafter. And hopefully when it does, it won't be giving us that rate anymore. That's chemical cardioversion. So adenosine is the drug they'll use for that. But to prevent it from happening again, they may give the calcium channel blockers or beta blockers, the rate control drugs. Now look at this one. See how wide those QRSs are? Wide and bizarre QRS, that tells us ventricular. And it's fast, isn't it? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18. So 180 beats per minute with wide QRSs all up and down. That's a ventricular tachycardia. This one will not perfuse for long. So this one's very serious as well. and it's generally treated with lidocaine, cardioversion, radiofrequency, or the drug amiodarone. Amiodarone. When it comes to the cardiac drugs, there's really not that many you need to remember. You need to remember the rate control drugs slow the heart down. Calcium channel blockers, beta blockers, and digoxin slow the heart down. You need to know that atropine speeds it up. You need to know that adenosine will stop it as chemical cardioversion. And you need to know that amiodarone is good for pretty much every irregularity, to get rid of any kind of irregularity, particularly the ventricular ones, but it'll do the atrial ones as well. Now look at that one. That's just all over the place. You can't tell what's what. That's the ventricles fibrillating. May not be this coarse. This is a simulator one. May not be this coarse, but that's the ventricles that are fibrillating. So that is BFib. Another term for BFib is death. And one of the things we have to remember with BFib, if they have pulseless VTAC or pulseless BFib, is we have to defib. So if your patient is showing on the cardiac monitor that or that, and you check the pulse and there is no pulse, then the first thing you're going to do is defibrillate that patient. That's what your cardiac, your CPR devices, one of the those things, the defibrillator devices, that's what they're looking for. They're sensing for VTAC, VFib without a pulse rate. And that's asystole. It's not truly a flat line like you see on television. There's usually some movement line in there, but it's still just asystole. It's nothing. People do not recover from that. We'll talk just a little bit about ST elevation. The ST elevation needs to be about 4 millimeters above in order to really be considered significant, above the baseline. So here's one that's pretty elevated. This one's pretty elevated here, here, here. This one has developed a little Q wave. So it's here and here, this little wave, see this one doesn't have, but maybe a little bit of a Q wave there. This one has a Q wave. It's developed a little Q wave in addition to the ST elevation that is occurring. This is indicative of a myocardial infarction, specifically a Q wave myocardial infarction. Just a little Q wave. This is ST depression. Again, the ST depression needs to be about 4 millimeters before it's really significant. It will usually tip that T wave over onto its inverted side. Most of the time just means old ischemia. It could mean that there's an MI, but most likely it's old ischemia. You don't have to remember this, but I like this little chart to show that if you have changes in lead 2, 3, and AVF, then that indicates that the infarction is in the inferior wall. And then elevations in these and depressions in these is lateral. Changes in V3 to V4 is anterior, V1 to V2 is septal. Marked depression in V1 and V4 is posterior. And V4R, lead V4 on the right chest is right ventricular. So these kind of give us an idea by looking at where the changes occur. You can't just look at one lead, you got to look at multiple leads. It tells us where the infarct is. And so these are all the areas possible for the myocardial infarction. So it would look something like this. There's ST elevation here, and then reciprocal changes seen in 1 and AVL. So here and here have reciprocal changes. So this is an acute inferior wall MI. I really don't expect you to remember all that. What I really wanted you to see was how they're determining that. How they're saying to you, oh, this is an acute inferior wall MI. It's by this ST elevation here in leads 2, 3, and AVF. That's 1. here. So you can see that ST elevation here, here, and here. And then you have the reciprocal changes in one, and ABL tells them it's an acute inferior wall MI, compared to this one, where you have ST elevations in view 2 and 3, and then you have reciprocal changes in view 2 and ABF in view 3. So here's view 3. I don't see the blue dot though. But that then tells us it's an acute septal MI. So when these providers are looking at these EKGs, they're looking for these changes, the changes and then the reciprocal changes to determine where the MI might have occurred. And then this one shows you bundle branch blocks, what they do to the change. This is a left bundle branch block in lead 1, gives you the little bunny ears. And view 1 gives you the little bunny ears for the right bundle branch block. That's usually what we're looking for. When you hear the nurses say, oh, they've got a bundle branch block, they've seen those little bunny ears on that QRS. Any questions? Okay. Are we ready to take our dosage count? Woohoo! I'd be more excited if we